Good morning, everyone. Here is the second part of our presentation about dental implant. Consider the bone density. Bone density is the amount of bone tissue in a certain volume of bone. The density of bone is often dependent upon the arch position. The denser bone is usually seen in the anterior mandible, then the anterior maxilla and posterior mandible, and least dense bone is found in the posterior maxilla. For bone quality, there is 4 categorization. Quality number 1 consists of homogeneous compact bone. Quality 2 composed of thick layer of compact bone surrounding dense trabecular bone. Quality 3 has a thin layer of cortical bone surrounding dense of trabecular bone. Quality 4 has a thin layer of cortical bone surrounding low density of trabecular bone. 4 bone densities found in edentulous regions of maxilla and mandible. Density number 1, bone is a primarily dense cortical bone. Density 2, bone has dense to porous cortical bone on the crest and has coarse trabecular bone. Density 3, bone types have a thinner porous cortical crest and fine trabecular bone in the region next to the implant. Density 4, bone has almost no crestal cortical bone and fine trabecular bone. The fine trabecular bone composes almost all of the total volume of bone next to the implant. Bone contour. The contours of the alveolar ridge, especially labially in the maxilla, are critical and very important, for they determine the emergency profile of the implant and can have a profound effect on its appearance. Here is a picture of excessive labial placement led to the loss of bone and apical migration of the peri-implant tissues, exposing the abutment and the implants. The contour of peri-implant tissues are primarily determined by the support provided by the underlying bone. Poor bone quality. This is a term often used to denote regions of bone in which there is low mineralization or poor trabeculation. Osteoporosis is a condition that results in a reduction of mineral bone density. However, the effect of osteoporosis must be a little significant in the majority of patients. Osteoporotic female, note the trabecular network is disrupted in 2 locations around the second premolar. For a treatment sequence, first of all is patient information. The patient should be fully informed about treatment alternatives, their advantages and disadvantages, the probability of implanted treatment failing, and the alternative if this occurs. Implant placement sites. This stage involves deciding on the most suitable implant sites bearing in mind the bone volume, bone quality, surgical factors, biomechanical considerations. Osteotomies must be double-checked for parallelism and proper positioning. Multiple implants being placed must be verified with placement pins. Implant placement. This may be carried out under local anesthesia with or without sedation or under general anesthesia. Antibiotic coverage is widely recommended. The bone is exposed surgically and a series of concentric holes drilled to accommodate the implant body. Once the implants have been placed, they are covered with a mucoperiosteal flap. Typically, the implants remain buried for 3 months in the lower jaw and 6 months in the upper, after which they are exposed and connecting component placed. The implant osteotomy sites must be prepared precisely with minimal trauma before implant is placed. A counterpore was used to develop the countersink area. Implant placed with conventional angulation and spacing. Implant mounter used to deliver the implant into the osteotomy site. And this is implants after healing. Immediate placement of dental implant, as in this picture in the top right, fractured maxillary central incisor seen radiographically, and this is clinically after extraction. Implant placed immediately after extraction, temporary abutment placed for temporary crown, and final restoration completed. Following extraction, the alveolar ridge is irregular as pictured in the top right. The ridge following alveoloplasty, which is a smoothing of bone, and the extraction socket was grafted with hydroxyapatite and beta-tricalcium phosphate. 3 months later, the alveolar ridge was exposed, and note the ideal alveolar ridge contour. Recently, resorbable membranes have been favored. Graft material in position. The membrane secured in position. Several months later, the membrane has resorbed. The evaluation of clinical success of dental implant quality of health scale suggested by James and divided into 4 groups. Group 1, in which it is success, no pain or tenderness upon function, no mobility, less than 2 mm crystal bone loss from initial surgery, no history of exudate. Group 2, satisfactory health, no pain on function, zero mobility, marginal inflammation of mucosal tissue, crystal bone loss 2 to 4 mm, no history of transient exudate, prognosis good to very good. Group 3, compromised health, slight to moderate peri-implantitis, sensitivity on function, radiographic bone loss less than 4 mm, no mobility, probing depth less than 7 mm, may have exudate history. Group 4, clinical or absolute failure, implant removed, pain, mobility, uncontrolled progressive bone loss, uncontrolled exudate, 50% bone loss, surgically removed or exfoliated implant.